In orthopedic and trauma surgery, we use different kinds of plates and screws. This is an example of a combined plate. In this plate you can use angular stable screws or conventional screws to fix fractures. Angular stable screws are used in very osteoporotic bones. Conventional screws are used to reduce fractures or to fix plates on bones. I will now show you the difference between these two kinds of screws. The angular stable screw is fixed in the plate and is now stable. You cannot stabilize a normal screw or conventional screw in these kinds of plates. The main difference between these kinds of screws is the head of the screw. After reduction of the fracture, a plate is attached on the bone. We now drill a hole for the screw. To get the right length of the screw, we have to check the distal part of the bone. The surgeon feels it with the screwdriver or the driller. After we have drilled the hole, the right length is measured and the appropriate screw is attached. We first use a conventional screw. You can do this by hand or using a machine. If you use a machine, be aware not to over-tighten the screw. By using a conventional screw, you can see that the screw now brings the plate to the bone. The plate is now fixed on the bone and is relatively stable. If we have a good bone, this screw will hold the plate in place. In very osteoporotic patients, this screw could loosen after a while. The angular stable screw is fixed in the plate. It is essential not to over-tighten the screw in the plate. And the difference between conventional screws and angular stable screws is that the conventional screw fixes the plate to the bone, whereas the angular stable screw fixes into the plate. Now the plate and the screw are fixed. One of the advantages of angular stable screws is in osteoporotic bone. This is a model of an osteoporotic bone. For drilling, we use 40,000 rounds per minute. To avoid heat necrosis, you should not press too much on the bone and always use sharp drillers. I control it with the foot control. As a surgeon, I feel the distal part of the bone, the distal cortices. It is essential not to press too much against the distal cortices. By using conventional screws, it is more likely that the screws will dislocate. The plate is now fixed with a conventional screw to the bone, but the screw is not fixed with the plate. If the patient moves now, there is a motion between the screw, the plate, and the bone. By doing repetitive motions, the screw will loosen in the bone. We now use angular stable screws. The plate is also attached to the bone. But is not compressed to the bone. It acts as an internal fixator. It is essential not to overcompress these screws. If you do repetitive motions, the plate is better fixed to the osteoporotic bone. Therefore, it is advisable to use these kinds of screws and this kind of fixation in osteoporotic patients. When milling the bone, we use 8,000 rounds per minute or up to 40,000 rounds per minute. If you have a mild exostosis, you can use 8,000 rounds per minute. We can also use 40,000 rounds per minute to remove larger exostoses. I normally use the foot control for doing these procedures. The surgeon has always to be aware to avoid heat necrosis, as this compromises the bone healing. Via the foot control, the surgeon is able to regulate the coolant supply and can guarantee for a sufficient cooling effect on the surgical site. This is essential, for example, in procedures called orthopedic, to fix an osteoarthritic joint.
W&H. People have priority.